Good afternoon. I'm Marek Mirski from Johns Hopkins Hospital in Baltimore, Maryland, USA.
I'm Audrey De Jong from Montpellier Hospital in south of France.
We're going to have a game show today. No, we're not. We're going to hopefully provide you some information and you give us feedback and ask us questions about how to decrease the complications of ICU intubation. And what we'll do is we'll start out with a clinical case and go on to some early metrics about how we do things. And then please raise your hand at any time if you have a question. Okay?
Okay, so let's go. Because I think we have many things to do. Okay. It's Mr. T, 65 years old. He has acute respiratory failure. And finally, he needs invasive mechanical ventilation. So you have to perform intubation. And I want to ask you one question. What are the two main complications of intubation procedure in ICU, of course, in critically ill patients? Who wants to try? Yeah? Congratulations, that's the good answer. Hypoxemia and hypotension, yes. So we have many studies about that. The first study was performed in France by the team of Samir Jaber. And they found that the two main complications of intubation was hypoxemia and cardiovascular collapse. And as you can see, for example, difficult intubation was less frequent. So was esophageal intubation. So it's very different than the complication we can observe in operating room, for example. And the last international study in almost 30 countries showed the same results. Sorry. But hypotension was winning, as you can see, 43%. And hypoxemia was still the second one, about 9% of patients who experience hypoxemia. And death and cardiac arrest, do you know the rate in ICU? It's about 3%. Who already experienced cardiac arrest in a patient with intubation in ICU? Nobody? Me? I'm the only one? Okay, so many persons, that's normal. We can predict difficult intubation in ICU. We developed a score a few years ago, and there is some intrinsical parameters. So the Malampati score, the mouth opening, the apnea syndrome, which is also one risk factor, and then we have other factors related to the pathology, as coma and hypoxemia, and of course the lack of experience in intubation. So we continue with Mr. T. You want to prevent hypoxemia, we agree. So how can you increase oxygen reserves? Let's go. I'm sure you know it. Yeah? Pre-oxygenation, yes, very well. And how do you pre-oxygenate it? You or over? How do you pre-oxygenate? With a mask? Fisher mask? Facial mask. Sorry, I'm French. So facial mask, yes. And if you want to even increase more oxygen reserves, how can you do? High flow nasal oxygen or Optiflow, the brand name, yeah. Over. CPAP, yes. And even more than CPAP. Non-invasive ventilation, so pressure support, more PEEP. So the best method, given the literature now, to increase oxygen reserves in the patient with hypoxemia is non-invasive ventilation. So it was shown in a randomized control trial 20 years ago. Non-invasive ventilation performed better than facial mask. And it was confirmed last year. It was this beautiful paper published in the New England Journal of Medicine, testing non-invasive ventilation for pre-oxygenation. And in almost every setting, in all patients, the risk of hypoxemia decreased when using non-invasive ventilation. But the control group was often standard oxygen. What do you think? Is non-invasive ventilation or high-flow nasal oxygen better? Who say non-invasive ventilation? We are in the hypoxemic patient, okay? And who say high-flow? Okay. So it depends on the level of hypoxemia. This very nice trial, multi-center, compare non-invasive ventilation versus high-flow nasal oxygen. But high-flow, and you see the title is very well written, it was oxygen with apneic oxygenation. So it was not the same thing we compare. Non-invasive ventilation when we remove the mask, and apneic oxygenation, more peroxygenation using high flow. In the overall population, no difference, so you are all right. And when focusing of hypoxemic patient with PaO2 under and VO2 ratio less than 200 millimeter of mercury, non-invasive ventilation performed better than high-flow nasal oxygen to decrease desaturation during intubation.
Let me ask you, what are the limitations of high flow? It's an attractive way, but compared to non-invasive, what do you not typically get, at least in an awake patient, in an asleep patient, or someone who's not very responsive? Yes, yes. And if you want PEEP, or the equivalence of it, you need someone who's able to keep their mouth closed. And you can't typically do that in an ICU patient who needs to be intubated sort of semi-urgently. So take control of the airway with non-invasive, in the end, gives you more control and typically better oxygenation, I think.
And during non-invasive ventilation, also you can monitor capnography. So the capnography is here, ready also for after intubation. We do that. Who performed bag mask ventilation or ventilation with the ventilator, waiting for the action of rapid sequence induction drugs? You perform a rapid sequence induction, for example, ketamine and succinylcholine, or we will see the drugs later, and you have to wait at least 30 seconds, agree? So during these 30 seconds in the critically patient, who ventilate the patient? Yeah? 1, 2, okay, 3. Yes, half of the room. I learned at school that it is forbidden to ventilate, but recently I was doing that, but in secret. Maybe you did the same. But recently we have this this very good study from the same team of Jonathan Cazé and Todd Rice. And they studied bag mask ventilation during apnea. It was critically patient at risk of aspiration, but not vomiting actively, of course. And this patient, it was at risk of aspiration because critically ill, but not full stomach. We were not sure of full stomach. And they showed that the lowest arterial oxygen saturation was much higher when using ventilation than without ventilating the patient. This was an expected result. And one secondary result, it was we had no difference in terms of aspiration rates between groups. So in selected patients, it could be interesting if you have an hypoxemic patient before intubation. And what we did in our unit is a single-center randomized control trial who compare non-invasive ventilation and non-invasive ventilation, more high-flow nasal oxygen during intubation. And we show also promising results, but it was limited by the sample size and the single-center design. So you have many things you can do, and I think the main message is to individualize the strategy according to the patient. So, Mr. T, which drug? Which drug do you use for intubation? I think it's interesting to see. In France, we perform almost always a rapid sequence induction. Is it the same in USA in critically ill patients, or?
Well, we get to some slides a bit
After?
later.
Okay. So first, I talk of what I know and what I practice, rapid sequence induction. So the drugs we can use are etomidate, ketamine, propofol, and the neuromuscular blockers, succinylcholine and rocuronium. Do you know in the INTUBE study, the big one in 30 countries, what was the only modifiable factor of cardiovascular collapse in the multivariate analysis? There was one single factor, which is in this slide, of course, which was associated with severe cardiovascular collapse. Propofol, yes, propofol. So the main risk is hemodynamic compromise, so we have to be very cautious when using propofol, and maybe we should prefer other drugs such as etomidate or ketamine. Recently, I don't know if you see the recent paper in the Blue Journal. It was an observational study in an American database, and they compare etomidate and ketamine, and etomidate was associated with higher mortality. There was limitation, it was a database. Of course, all the confounding factors were not all taken into account, but added to the risk of corticosurrenal insufficiency of etomidate, maybe we could choose ketamine for first attempt, but it's not a strong level of proof. Regarding the neuromuscular blocker, we use either succinylcholine or rocuronium. What are the advantages of succinylcholine over rocuronium? Is there any advantages?
It's the fastest drug available.
Yeah, the fastest. Yeah, and so also a slight improved glottic visualization, but we have also very good glottic visualization with rocuronium. And the onset is less rapid, more than 45 seconds. Now we choose the drugs, and we have to choose the material to perform intubation in Mr. T. So which material would you use for first attempt in this patient? Sorry? Videoscope, yes, videolaryngoscope. Others? No? Yeah, videolaryngoscope also. So everybody would use a videolaryngoscope. Okay. If possible, yeah, okay. Yes, I would do the same because in our unit we are doing always a videolaryngoscopy for first attempt. And you can... I was not expecting such high rates of videolaryngoscopy, so I prepare slides for direct laryngoscopy also. If you have only direct laryngoscopy and that you want to increase first attempt success, you can use a stellate in the tracheal tube. It was a study showing that. You can use either a stellate or a bougie. It's quite the same. It depends on your expertise. And you can do what you prefer. And again, this nice randomized control trial performed in critically adults showed that first attempt success was increased with videolaryngoscope compared to direct laryngoscope, but there was no difference in the rate of complication, surprisingly, because we increased the first attempt, we expected less hypoxemia, but not. Maybe because we ventilate the patient quite early if we don't succeed, and that's quite good. So that's the secondary outcome, no difference among the secondary outcomes. The blade, if you are doing a standard direct laryngoscopy, can also be interesting. And it was an observational design, but the first attempt success here with direct laryngoscopy was higher with Macintosh blade number 3 compared to 4. I was quite surprised by these results. Of course, in patients with obesity or tall patients, we still have to use 4 Macintosh 4 blade. And I think it's your turn. After that...
Is anyone surprised about that, about a Mac 3 versus a Mac 4? I think it teaches you one thing in ICU and anesthesia is that size makes a difference. Bigger isn't always better. The same thing with the oral airway. You know, usually someone hands you an oral airway because you need to put a block in, and the respiratory therapist gives you like the largest one available. And that's not necessarily the best. You know, you want to match it to the angle of the jaw. And the same thing with a Mac 3 has a bigger curvature, but for a normal airway, that'll help you. A Mac 4, if you have a large person, you know, large head, then you need a depth for sure. So anyway, nasal trumpet you also would measure, right, to accommodate the patient's nasal structure. Anyway, so I just wanted to emphasize that when you intubate in the ICU, a couple of things are ICU intubations are much more difficult. It's been shown, I don't know if I have the slide here, but then intubations in the OR. Just look at what the patient's lying on, the bed. That's a tragic a structure to be held on to provide you with the optimal airway. You know, a lot of them are on the floating beds and the mattresses. Difficult to get the nice extension, the head lift. So you have to recognize you're working behind the 8-ball, so to speak, in terms of the ICU. So be careful. The success rate in the ICU, I think, is around 70 to 80% on the first attempt. In the operating room, it's up to 90-something%. So choosing your instrument, everyone here chose a glide scope pretty much, or video scope, which is probably the standard scope right now. But we talked a little bit about difficult airway. Just sort of mentioned that. I just wanted to get you a little more in depth here that there's a lot of difficult airways in the ICU population. Unless this is an urgent/emergent intubation, taking the time beforehand to analyze the airway as best you can and decide how you're going to prepare the patient, how you're going to prepare yourself with the equipment available and the team available. Someone who has a questionable, difficult airway presents a whole list of new things you should consider, like fiber optic intubation. Should you put the patient to sleep at all? Maybe this is an awake intubation. The awake gives you the safety that they control their airway and their ventilation. So you have that time that you can actually fail and pull back. You miss on rapid sequence and you get into the situation that you can't ventilate because you gave relaxant and the structures closed down on you because there's some, you know, it wasn't that open to begin with. Then you get very nervous and stressed out and call for help. And those are the big complications you want to avoid. So I just wanted to show you that we use fiber optic plenty, as well as overt video endotracheal intubation. Again, nasal versus oral depends on what the problem is. Like in this patient, it would be probably an easy task to put a nasal tube down in the awake or very slightly sedated patient. You put this patient to sleep, that tongue falls back even with your blade, and that airway may disappear even with the video laryngoscope trying to get up the angle, and you could be in trouble. And in our country, if you get in trouble, you go to court. It's as simple as that. So we...
Maybe with this one also we will perform fiber optic intubation.
What's that?
With these patients,
yes.
we will do fiber optic intubation, even in France. Yeah.
So here's just what... There's a lot of advantages to fiber optic as well because you can also clear the patient out. Many of the reasons you're intubating the patient is for respiratory failure, maybe due to a pneumonia, so you can do a cleansing, if you will, of the airway. And this is probably yours, right? Yes.
Yeah.
Thank you.
Thank
Any
you.
questions so far? Because we want to make sure we get your questions in this rather short period of time. Okay.
It's okay. Don't hesitate to interrupt if we have more questions. So now we want to decrease severe collapse. We saw that it is the first complication of intubation. So how can we decrease severe collapse following intubation? It's your turn. Vasopressors, yeah, starting before intubation. Yeah, and how do you put vasopressors with a central venous access or a peripheral line? Yeah, with the micro. Yeah. Thank you.
In this case, we could start it peripherally.
Peripheral, yes. And which dosing? Which?
Due to our necessity to gain something like 140 systolic.
Okay.
Safe zone.
I was meaning which dilution?
Preferably 1 to 100.
Okay. Okay, overreaction? No, also in peripheral line we can do vasopressors with a dilution, higher dilution, or also classic dilution if the peripheral line is dedicated to the vasopressor, of course. Over means to decrease severe collapse. No, only vasopressor. You all know the recent literature.
I would like to preface, as you're going to induce the patient, to recognize how ill the patient is, either systemically or neurologically, because when you induce with medications like etomidate or propofol, in the ICU you need not and probably should not go by any guidelines you see in the records about how much you should give of those drugs. 2 milligrams per kilogram of propofol in an ICU patient will put them in complete cardiac arrest. You can do as little as half to 1 milligram per kilo and get away with it, because what you want to do is make them unconscious, especially in the context of giving rapid sequence. When you're giving relaxant as well, you're not using the depth of your induction agent to get muscle paralysis or weakness. So all you're doing is trying to get the patient to sleep, and a strong sedation dose is more than enough for most patients. And you can then hopefully even get around the fact that these are very hemodynamically unstably producing agents.
Yes? Position of the legs, yes. But yeah, it's interesting, but often you have to put the patient semi-sitting for avoiding desaturation, so it's difficult. So again, we have to assess the benefit-risk ratio, but in selected patients, yes, why not? And when you say position of the legs, it's to increase preload and cardiac output. So also we have to check that the patient has not hypovolemia before intubation, and perform, for example, point-of-care ultrasound and optimize volemia before intubating this patient. So it was a bundle a few years ago, including fluid bolus and vasopressors, and it allowed to decrease the rate of severe cardiovascular collapse. And after we had a randomized controlled trial, in summary, there was no difference between groups. So if you are doing fluid bolus or not, excluding hypovolemic patients, it's important, the patient with hypovolemia were excluded, there is no difference. So maybe it's not fluid bolus for everyone, but fluid bolus in selected patients after monitoring, as you know, hemodynamic management. So it was one of the first studies showing that, and the second study showed the same thing. No effect of fluid bolus administration alone. But however, the combination of fluid bolus and vasopressor was never assessed. So maybe if we do both, it could have a different effect. So to summarize, here's the update of the Montpellier intubation protocol. So for the one who want to take a picture, it's all what we said before. We've also an additional point about cuff pressure, of course, monitoring of cuff pressure to avoid tracheal lesion. We didn't talk about Selic maneuver. Who still perform the Selic maneuver in the room? Yeah? Me too, in selected patient, yeah. What do you think of Selic maneuver?
I use it.
You use it also, yeah.
Yeah. I mean, the studies aren't convincing one way or the other, but I do think that putting pressure does occlude the esophagus to an extent. So cricoid pressure is...
Yes.
Cricoid, yes?
Yes, cricoid pressure.
It leads to another question I had. When you intubate in the ICU, do you have the patient flat? Good. Yeah, okay. I would do the same. Even though if you read the textbooks, it'll say lay the patient flat. But if you have them slightly elevated, you also get rid of you have gravity help you in terms of the aspiration risk. And also if they're large people, they'll tend to have the chest come down as well, too, and make things a bit easier. So, yeah, I use 20 degrees up for most of the patients.
There are, for the visual one, there are images summarizing pictures, summarizing what we did. And recently we did an international Delphi study with Sheila Miyatra and Kunal Karamchandani about tracheal intubation in critically ill adults, and it was about the physiologically difficult airway. It's a new notion. It's what we'd say all these 30 minutes, that the physiologically difficult airway, it's not always the anatomical difficult airway, but in ICU we have a physiologically difficult airway. And here you have the summary of this management of difficult airway. So the pathophysiological alteration, hypoxemia, cardiovascular instability, right ventricular dysfunction, increase in tracheal pressure, the physiological alteration that do not help, obesity, pregnancy. And here the management. What we didn't talk about is the healthcare providers, and we advise at least 2 airways operators, so it's not possible in every setting, because sometimes we are alone to perform intubation, but in this very high-risk patient, it's always better to be 2 than alone. So 4 hands, for example, to perform ventilation if we can, or to aspirate the patient. Then the patient preparation, head of the bed at 30 degrees, pre-oxygenation with non-invasive ventilation, optimization of hemodynamics using vasopressor and or inotropes, and point-of-care ultrasound. Then the tracheal intubation. So in a difficult case, we can do fiber optic intubation if the anatomical airway is really difficult. If not, modified rapid sequence induction. Why did we call that modified? Because we can use careful mask ventilation in patients who are not at very high risk of aspiration or vomiting. Avoid, I did a mistake. avoid the standard doses of propofol, if possible. And then after intubation, when you set your ventilator, how do you set your ventilator? Yeah, low pressure at the beginning. So even if the patient has an acute respiratory distress syndrome and need very high peak, you have 5 minutes to optimize the hemodynamic states before setting high peak, for example. For first attempt, it's now demonstrated that video laryngoscopy, as you said, perform better. And finally, post-intubation, confirmed tube position and capnography, when you have it, is advised worldwide. And, of course, manage cardiovascular instability and any other complication. Do you have one burning question after that?
Which method do you prefer for anatomically difficult airways? Is rapid sequence intubation or awake intubation?
Or up.
Or awake
Intubation.
or rapid sequence?
Yeah,
Thank you.
You've answered your own question. If you start out with a question by saying in an anatomically challenging patient, you take away the normal induction rapid sequence off the table because you've already identified a problem with the patient. So either it's going to be awake or it's going to be asleep, spontaneously ventilating, for example, fiber optically, but you play it safe if you aren't convinced that you have an easy access. And I was going to ask, what other tools do you have by your bedside when you just do a routine intubation in the ICU? You're not expecting a problem. What do you have ready to reduce the complications? Does everyone have an LMA with them? You should. Do you have an oral airway, a nasal trumpet, all those different blades? So be prepared.
Yes, that's why I saw the airway management algorithm. So if the patient is really difficult to intubate, first fibroscopy. If the mouth opening is okay and it's not a real difficult intubation, you start using video laryngoscope. Then intubating stillate, almost mandatory with the video laryngoscope. We did not talk about that, but in critically patient, we always use a stillate. If the video laryngoscope is hyperangulated, we use a dedicated stillate for the hyperangulated video laryngoscope. And then, as you said, the laryngeal mask, fast track or not, the fast track is not advised anymore, but a laryngeal mask in order to be able to ventilate the patient and sometimes intubate the patient.
Follow up to your question, which was more nuanced than perhaps one could think originally. If you feel that there is a question about how easy the intubation might be because of the airway anatomy, keep in mind, especially if the patient's awake, they usually have no problem having you talk through them a fully awake, unsedated direct laryngoscopy. And not that you're going to intubate with that, but just get a look to see if you can pull the tongue up, if you can see the bottom of the epiglottis or the arytenoids, you're golden. And sometimes the difficult airway looks difficult, and then you just do that, and you go, oh, this is standard. And then you go right with your intubation. Or you lift up and you go, oh, my God, all I see is pink. And then you revert back to your more conservative pathway. I've done that many times, and it's worked. Yes?
Thank you. But will the patient cope with anawake ventilation when being severely dyspneic at rest? Because, whenever I have attempted to do an awake ventilation in an acutely ill patient, what I found was that the patient did not cope for intubation. And if I tried to sedate the patient, I had to intubate quickly. So I have the feeling that awake intubation is not for acutely ill patients. I might probably be wrong.
Well, in my experience, if you're saying awake intubation in the ICU, you're talking fiber optic nasal. And with that, they tolerate, many of them. If you assuming it's not an emergency and you have the time to anesthetize the nares, lube it up, get the tube down, that they won't even know it's happening practically. But it would be a nasal fiber optic. You're correct. Thank you.
Thank you very much for being here. And I think we have to conclude. We already are over time. And thank you again.